Welcome to Online Anesthesia Video of the Week. Today is presented by Dr. J. Edward Johnson, Professor and Head of the Department of Anaesthesiology, Kanyakumari Government Medical College. He is an Associate Editor of Indian Journal of Anesthesia and past President of ISA Tamil Nadu State. His love and interest on teaching through social media makes him being Chief Editor of Online Anesthesia Teaching Programs.
Morning. Welcome to another edition of Online Anesthesia. Myself, Dr. Edward Johnson, Professor and HOD of Department of Anesthesiology at Kanyakumari Medical College. Today we are going to see an important topic, that is sudden desaturation in the intraoperative period. Sudden desaturation that occurs in the intraoperative period is always a nightmare for any anesthesiologist. How to approach this sudden intraoperative desaturation? If you see the incidence of hypoxia during intraoperative period, this statistics is taken from the two leading institutions, and it is published in the Canadian Journal of Anesthesia. They have analyzed more than 15 million SpO2 readings, and only 0.37% of the readings are less than 90%. More than 99% are SpO2 more than 90%. So the incidence of hypoxia is less, but it is always a nightmare to the anesthesiologist. This is the incidence taken from the Ehrenfeld et al. Published in the Canadian Journal of Anesthesia. The hypoxia is infrequent, that is 6.8%. Among the hypoxia, severe hypoxia, that is SpO2 less than 85%, occur only in 3.5% of the patients. And majority, that is 99% of the transient hypoxic episodes were relatively brief, that is less than 5 minutes. The transient hypoxia occurred during all phases of anesthesia, both during induction, maintenance, and emergence. If you see the incidence, it is more common in the maintenance period. The main reason is your hypotension and anaphylactic, and it is less in the recovery period, that is extubation period. It is mainly due to the laryngeal spasm. It is more common in induction. It is due to difficult intubation and bronchospasm at the time of induction. So let us see the causes of hypoxia in the intraoperative period. It can be divided into two broad categories, that is problems with the oxygen delivery system and problem with the patient. We will see one by one. So the problems with the oxygen delivery system, it may be due to the oxygen source or the anesthesia delivery. The oxygen source, it may be at the level of central oxygen supply or at the pipeline system or at the cylinders attached to the oxygen cylinders attached to the anesthesia machine. Or the problems may be anesthesia delivery system, that is anesthesia machine, anesthesia ventilator, anesthesia breathing circuits, or your endotracheal tube. So at the level of central oxygen, there may be a failure of the master alarm system in the central oxygen system, or liquid tank may be filled with raw gas, that is nitrogen or argon, or there may be a gas leak, or inadequate pressure at the central supply which is gone unnoticed, or a decreased oxygen level in the tank, or depleted tankers may be the reason. So coming to this distribution system at the theatre level, there may be a connecting wrong hose to the oxygen yoke, that is rather coupled in the anesthesia theatre wall mount. So inadvertent switching of the starter adapter of pipelines may be the cause. In the distributing system, there may be a leak in the pipelines, or contamination of the gases, or cross connection of the pipelines. At the level of the oxygen cylinders attached to the anesthesia machine, there may be empty cylinders or substitution of non-oxygen cylinders at the oxygen yoke. It may be done by applying more than one Borax seal. It has happened in many situations, and insufficient opening of the cylinders may be also the one of the cause for the hypoxia. So at the level of the anesthesia machine, it is incorrect setting of the flow meter, or any crack in the oxygen flow meter which goes unnoticed, or maybe a transmission of the rotameter tubes or leak in the machine. At the level of the anesthesia ventilator, low tidal volume may be supplied, or low respiratory rate, or inadequate minute ventilation, or any disconnection of the tubing in the ventilator system. At the level of the anesthesia circuit, there may be a disconnection or leak. At the level of the endotracheal tube, esophageal intubation may be the cause, or endobronchial intubation due to the change of position in the intraoperative period, and accidental extubation due to the same change in the position in the intraoperative period, or thinking of the tube, or tube obstructing the opening of the right upper lobe bronchus in case of a one lung ventilation. So at the level of the endotracheal tube, there are many causes. The wrong tube, it may be a small tube or not armored tube, or not double lumen tube. We used a single lumen tube in case of a one lung ventilation. Misplacement, esophageal intubation, endobronchial intubation, bevel against tracheal wall, double lumen tube, it is too far inside the trachea into the bronchus, paratracheal or pharyngeal. Catheter mount, there may be a disconnect in the catheter mount, leaks, obstruction, failure to connect. Cuff problems, there may be leak, herniation of the cuff, or failure to deflate. Endotracheal obstruction, there may be kink. Patient may be biting the endotracheal tube. It may be blocked by secretions and blood. Where Boyle-Davis mouth gag may be obstructing the endotracheal tube. Nasogastric tube may cause a kink around the endotracheal tube. Surgeon leading on the endotracheal tube. Foreign body obstructing the endotracheal tube. The tube may be obstructed by a esophageal stent and unknown causes. So the catheter mount, ETT with catheter mount, it may be wrong tube, it may be too small tube, or not armored, or double lumen, not double lumen in place of a one lung ventilation. And endotracheal obstruction, most of the time the endotracheal tube is concealed under the trapes. So the surgeon may be leaning on the endotracheal tube causing obstruction. Where Boyle-Davis mouth gag may be causing obstruction, or any foreign body obstructing the endotracheal tube, secretions, blood, or anything it may be. Patient may be biting the endotracheal tube, or your gastric tube may be causing obstruction of the endotracheal tube, or esophageal stent may be obstructing the endotracheal tube. So displacement during change of position in the intraoperative period, or during intubation, it may go into esophageal, it may move to endobronchial, or bevel against the tracheal wall, double lumen tube which has gone too far inside the bronchus, or paratracheal or parapharyngeal. Cuff problem, there may be rupture of the endotracheal cuff, or there may be leak in the cuff, or failure to inflate, or herniation of the cuff may be the cause for the hypoxia. So coming to the problems with the patient. There is a second part. The problems with the patient, it may be due to ventilation, diffusion, or disparity between the demand and delivery. So ventilation, it may be hypoventilation, reduced functional residual capacity, or increased airway resistance, or atelectasis. In diffusion defect, shunt may be, VQ mismatch may be increased, or inhibition of the hypoxia-pulmonary vasoconstriction. Demand may be increased, delivery is reduced. Poor oxygen delivery to the tissues, increased oxygen demand. So hypoventilation, spontaneously breathing patients, your hypnotics and your narcotics can depress the respiratory depression, cause respiratory depression, and patient may go for hypoventilation and hypoxia. In paralyzed patients, your inadequate IPPV may be the reason for hypoxia. So reduced functional residual capacity. In case of general anesthesia, there is always a reduction of 15 to 20% of the FRC in the GA. This is due to the muscle relaxant you are using and patient supine position. The diaphragm may go upward into the thorax and compression of the basal alveoli causes basal atelectasis. Or it may be it is more pronounced in patients with pre-existing lung disease and obese patients. And the FRC reduction may be continued in the post-operative period also. It causes, FRC reduction causes, there is a gradient, this PaO to PaO2 gradient, that is alveolar oxygen and arterial oxygen gradient will be increased. Reduction in the FRC can be restored by applying PEEP. So this is the before induction CT chest, there is no atelectasis. The second picture, there is after intubation, there is basal atelectasis in the CT of thorax. So increased airway resistance may be due to many causes, due to reduction of the FRC, reduced caliber of the airways in bronchial asthma, and endobronchial intubation. Anesthesia apparatus, the resistance in the anesthesia apparatus may be the cause for increased resistance, or your laryngeal spasm at the time of extubation, or obstruction to the endotracheal tube by secretions or blood. So there are atelectasis is more common during general anesthesia. There are different types of atelectasis: contraction atelectasis, resorption atelectasis, compression atelectasis. In contraction atelectasis, what happens? It is otherwise called absorption atelectasis. That is, when you use 100% oxygen, it causes absorption atelectasis. If you use air, the oxygen that moves into the blood from the alveoli causes a little reduction in the pressure inside the alveoli, and the alveoli configuration is maintained by the retained nitrogen in the air. But when you use 100% oxygen, nitrogen will not be there. So oxygen moves from the alveoli into the blood. There will be negative pressure, cause collapse of the alveoli. It is called absorption atelectasis. In the resorption atelectasis, there may be a partial obstruction in the endotracheal tube. Partial obstruction in the trachea or bronchi that cause collapse of the alveoli. So the collapsed alveoli, there will be reduction in the secretion of the pulmonary surfactant. So pulmonary surfactant is essential for the alveoli. It keeps the alveoli distended. So reduction in the pulmonary surfactant causes collapse of the alveoli. So it is called resorption atelectasis. And compression atelectasis, it can happen due to the compression, like in general anesthesia, the upward displacement of the diaphragm, basal atelectasis, or surgical instruments by the surgeon also directly cause compression of the lung and alveoli, cause compression atelectasis. So how to avoid this atelectasis during general anesthesia? You can go for a recruitment maneuver. Follow that recruitment maneuver, you can apply the PEEP. Suppose you apply only PEEP, it causes the anatomical recruitment. So the alveoli get aerated, but the capillaries of the walls of the alveoli get compressed, and there is overinflation of the alveoli. Your PaO2, FaO2 is constant, and increased PaCO2 and reduced lung complaints will occur. Suppose you apply recruitment maneuver before applying PEEP, the alveoli get aerated, but there is no vessel compression on the walls of the alveoli, and there is a normal inflation, and your PaO2 and FaO2 is increased, and decreased PaCO2 and increased lung complaints occurs. So whenever you apply PEEP, it should be preceded by a recruitment maneuver. There are different types of recruitment maneuver. You can apply 40 centimeter of pressure for 40 seconds, or in stepwise recruitment maneuver. That is, first you apply 20 centimeter of water pressure for 10 seconds, then increase to 30 centimeter of water pressure for 15 seconds. Then third step, you increase to 40 centimeter of water pressure for 15 seconds. This is the stepwise recruitment maneuver. So coming to the diffusion defect, even though adequate oxygen is supplied to the alveoli, if there is a defect in the alveolar level that prevents the absorption of oxygen into the blood, that causes hypoxia. It may be due to thickened alveolar membrane, thickening of the airborne interface, or due to any inflammatory reactions, or pulmonary edema that interfere with the interstitial space of the alveolar capillary membrane. Then fibrosis and loss of alveolar surface area in case of a sarcoidosis and emphysema. Shunt, inadequate ventilation. I already told you absorption atelectasis with 100% oxygen. Then airway secretions partially obstructing and causes resorption of atelectasis. And pulmonary aspirations may cause hypoxia, or inhibition of hypoxia-pulmonary vasoconstriction by your vasodilators like SNP and nitroglycerin. Inadequate perfusion, that is pulmonary embolism. So the alveoli is ventilated but not perfused by the pulmonary embolism. So it is a wasted ventilation, and it may be due to pulmonary edema. So inhibition of pulmonary vasoconstriction, hypoxia-pulmonary vasoconstriction, it is a protective mechanism. Whenever there is a reduction in the ventilation of the alveoli, the blood supply to the unventilated alveoli is reduced by vasoconstriction, and the blood is diverted to the ventilated alveoli. This is the protective mechanism of hypoxia-pulmonary vasoconstriction. It is inhibited in case of inhalation anesthetics. All inhalation anesthetics suppresses the hypoxia-pulmonary vasoconstriction, and your vasodilators, sodium nitroprusside, nitroglycerin, they dilate the blood vessels in the unventilated alveoli. So it is a wasted perfusion. And your hypocapnia, hypothermia, the thromboembolism all inhibit the hypoxia-pulmonary vasoconstriction. So poor oxygen delivery to the tissues. So there is a disparity between the demand and supply. Supply is reduced in case of a systemic hypoperfusion, embolus, sepsis, and local problems like cold limb, Raynaud's phenomena, and sickle cell disease. Increased oxygen demand in case of malignant hyperpyrexia, shivering, and sepsis. So hypoxia during special situations, you have to take additional care. In case of a laparoscopic surgery, it is very common because due to the pre-existing conditions like obesity, cardiopulmonary dysfunction, and hypoventilation that occurs during the laparoscopic surgery due to the position, pneumoperitoneum, endotracheal tube obstruction, and inadequate ventilation. The intrapulmonary shunting due to decreased FRC, pneumothorax, emphysema, and endobronchial intubation. These are the causes for hypoxia in the laparoscopic surgeries. So reduced cardiac output, your pneumothorax causes reduced venous return and hypotension, and arrhythmia, myocardial depression, and carbon dioxide embolism. These are the causes for the reduced cardiac output. They may also cause the hypoxia in the laparoscopic surgery. Coming to the pneumothorax, pneumothorax causes, intraoperative pneumothorax causes decrease in FRC. It is common in the COPD and patients with the blood injury chest, and your central line insertion can cause pneumothorax in the intraoperative period. According to the 10th edition of ATLS, American College of Surgeons textbook, if the pneumothorax is in the pediatric patient, you have to put the needle in the second intercostal space mid-clavicular line. In adult, it is fourth to fifth intercostal space anterior to the mid-axillary line. So in case of pediatric patients, because of the smaller diameter of the airways and the chest wall airways are highly compliant, and increased oxygen demand in the pediatric patients are more prone for hypoxia. Premature infants have a deficient surfactant and difference in the airway anatomy. There is a difficult intubation and mask ventilation in the pediatric patients. They are more prone for hypoxia, and early fatigue and apnea due to the lack of tight bone muscles in the diaphragm. And in case of pregnancy, FRC is already reduced to 20% and oxygen reserve is reduced in pregnancy. But oxygen consumption is increased 20% due to the placenta and fetus, and they are more prone for hypoxia even for a short period of apnea. So there is a difficult intubation in the pregnancy, and also we have to go for a rapid sequence induction using Sellick's milk. In case of elderly patients, there is compromised respiratory system and compromised cardiovascular system. Compromised respiratory system due to the loss of elastin, reduced compliance, increased residual volume, loss of vital capacity, and impaired efficiency of gas exchange, and increased work of breathing. And all the drugs, especially sedatives and narcotics and muscle relaxants, are prolonged in older patients. So in case of obese patients, anticipated difficult mask ventilation, difficult laryngoscopy, difficult intubation, all causes hypoxia, and decreased lung volumes, capacities for C, ERV, and VC. ERV is the expiratory reserve volume is the only oxygen reserve, and pre-oxygen is less effective. You have to go for a proper position and apply CPAP in the case in reacceleration. So FRC is further reduced the supine push. They are also sensitive to hypnotics and opioids. So during one leg ventilation, most of the time hypoxia occurs during the one leg ventilation. This is due to the VQ mismatch because non-dependent lung is not ventilated but continues to get perfused. So what you have to do is during hypoxia in one leg ventilation, you have to go for a 2-leg ventilation as long as possible. High FA you have to use 100% oxygen and begin 1-leg ventilation with 10 ml per kg tidal volume and adjust the respiratory rate to keep the PaCO to 40 mm of mercury. You monitor oxygenation and ventilation simultaneously. Non-dependent lung, you can use CPAP. Dependent lung, you can use PEEP. So intermittently, you can ventilate the 2 lungs. If the hypoxia is severe, you can go for clamping of the pulmonary artery. So diffusion hypoxia, this occurs at the time of extubation. So throughout the general anesthesia, we are using nitrous oxide oxygen 50%, 50%. But at the end of the surgery, if you expose the patient to the air, nitrous oxide is 31 times more soluble than nitrogen. So for every 1 molecule of nitrogen entering into the blood from the alveoli, 31 molecules of nitrous oxide enters into the alveoli from the blood. So it dilutes the oxygen in the alveoli and causes alveolar oxygen hypoxia. So this is more common during the first 5 to 10 minutes of extubation. So you have to administer 100% oxygen to overcome this diffusion hypoxia. So how will you diagnose the cyanosis, hypoxia? In early days, we wait for the diagnosis of hypoxia for the appearance of cyanosis. But cyanosis appears when the deoxygenated hemoglobin is more than 5 grams per 100 ml. And it is a subjective phenomenon. When there is cyanosis, the hemoglobin saturation is 85% and where PaO2 is 45 to 50 mm of mercury in case of adults and 35 to 40 mm of mercury in case of infants. Cyanosis will not occur even in hypoxia in methemoglobinuria, and cyanosis may not be apparent in case of anemia and peripheral vasoconstriction. So relying on cyanosis for intraoperative hypoxia is not advisable. So several monitors were used to detect hypoxia. Pulse oximetry is the commonly used. Other monitors are oxygen analyzer, ABG, and mixed-venous saturation. So recognition and management, you have only 3 minutes for the recognition and management of the hypoxia in the intraoperative period. So you can use cover ABCD algorithm. Here, COVER, C, circulation and color. You check for the peripheral circulation. If pulseless, you start CPR. Color, you check the saturation by pulse oximeter. Test the probe on your own finger if necessary. Then O, oxygen and oxygen analyzer. Check the rotameter setting in the flow meter. Is there any crack, leak, or shifting of the rotameters? And you check the oxygen analyzer. Adjust the inspect oxygen concentration to 100% and check the oxygen analyzer shows the raising concentration. Then ventilation and vaporizer. You ventilate the lung by hand, manual ventilation, and you can check the integrity of the breathing circuits. You can check the capnography and you can check the lung compliance and the airway resistance. Vaporizer, note the settings of the and level of the agents. Remember, leaks are more common in the low pressure system, that is in vaporizer. So you check the vaporizer. Then come to the E, endotracheal tube and elimination. Endotracheal tube, you check for any leaks or kinks in the endotracheal tube and check for corresponding changes in the capnography. And elimination, you eliminate the anesthesia machine and ventilate with self-inflating bag with 100% oxygen. Self-inflating bag with 100% oxygen means with another source of oxygen. In self-inflating bag is nothing but the ambu bag. And or review of the monitors, you review all the monitors, at the same time review the equipments also. Review the monitors, oxygen analyzer, capnography, blood pressure, ECG, temperature, and your neuromuscular monitors, and review your equipments like diathermy, humidifiers, heating blankets, endoscope probes, prostheses, retractors. You have to check the review of the equipments. cover ABCD. Now come to the ABCD. A, check the airway pattern. See, in independent airway, you consider the presence of laryngeal spasm, foreign body, blood, gastric contents obstructing the airway, nasopharyngeal or bronchial secretions causing the obstruction. Breathing. Assess the breathing pattern and adequacy of distribution of ventilation. And consider examine the auscultate over the chest for any bronchospasm or pulmonary edema, lobar collapse, pneumo or hemothorax. Circulation, you check the peripheral perfusion by pulse oximeter, blood pressure, ECG, capillary filling time, and also you check for the venous return, whether venous return is obstructed by your PEEP or pneumothorax or direct interference with the central line with the causing the pneumothorax or any tamponade of the heart. Drugs, failure of administration of the wrong drug, wrong route or wrong dose. So wrong drug should be eliminated. So complete cover ABCD first switch check. Then you can ventilate with 100% oxygen. Confirm the FiO2 is appropriate. Confirm the ETCO2 is appropriate. If it is low, consider anaphylaxis, pneumothorax or air embolism. Once again, auscultate for exclude endobronchial intubation. So there is algorithm. By using this algorithm, you can come to a diagnosis of hypoxia, what is the cause, and you can rectify it within 3 minutes. So according to this algorithm, first check the SpO2. If it is less than 95%, check the FiO2. If the FiO2 is low, to ventilate with ambu bag and eliminate the anesthesia machine, and check the flow rate and check the oxygen source, cylinders or oxygen center supply. Then you check the FiO2 and review the monitor by giving 100% oxygen and confirm the FiO2 also shows the 100%. If the FiO2 is normal, then check the ventilator graphic pattern. If the tidal volume or minute ventilation is low, you eliminate the ventilator and go for a manual ventilation. Then confirm the endotracheal tube position by auscultation, whether the endotracheal tube is endobronchial or is there any obstruction. If there is a pneumothorax, put an ICD. Then you assess the airway resistance. If the airway resistance is high, you deepen the anesthesia or use bronchodilator. Then assess the lung complaints. If the lung complaints is increased, then you apply PEEP. In one limb, if they check the peripheral circulation also, if the peripheral circulation is absent and there is a shock or hypotension, you start CPR and roll out anaphylaxis and embolism. So this is a simple algorithm you can use everywhere. You can come to a diagnosis within 3 minutes and you can rectify the oxygen hypoxia also. So prevention is better than cure. So you do a thorough preoperative optimization, and anesthesia machine check is a must. You check the oxygen source, whether the additional cylinders are available and central oxygen supply is okay. The pressure, check the pressure, and monitors the checkup. FiO2 monitors and your capnography, crash cart, all should be checked. And pre-oxygenation should be with CPAP and RSI, and aspiration prophylaxis. Adequate hydration should be there, and airway and ventilator strategy should be there, and drug labeling is a must. So the motto is vigilance. The patient is represented as the ship sailing in the troubled sea with clouds of doubt and waves of terror, yet being guided by the skillful pilot, that is physician or anesthetist, with constant and eternal, that is task. Vigilance motto by his dependable, that is lighthouse, knowledge of the art of the sleep, that is moon, to a safe and happy outcome of his voyage through the realm of unknown. Thank you. We will see you in another episode of online anesthesia. Thank you. Thank you very much.